So good morning, everybody, and welcome to this morning's session on transforming asthma care through system-wide collaboration and innovation. My name is James Rose. I'm the Head of Innovation Adoption at the Oxford Academic Health Science Network, and I'm doing a double act today with my colleague Joe.
Hello all, Joe Sladen. I'm at the Wessex AHSN, so South Coast. I'm one of the associate directors there, and I lead the national FeNO work. So James and I are becoming pretty conversed in double acts.
Thanks, Joe. So in terms of today's agenda, we're really keen to get four things really over to you today. We're really keen to share all the work that we've been doing through our Accelerated Access Collaborative and AHSN Network projects on transforming asthma care. We're really keen to share some of the impacts and the benefits that we're already seeing about halfway through the programme. And we're also looking to share with you how you can become involved in the programme itself. And I think we're really, really excited today to also be launching a pivotal piece of work that we've been working on the Asthma Biologics programme, which is around the ACC Consensus Pathway for severe asthma. We've got a short message from Dr. Natasha Rupani, who's going to be just talking us through the pathway, and she's been absolutely pivotal in bringing it all together, as well as many other stakeholders involved. So just in terms of who we are, for those of you who don't know, the AHSN Network is made up of 15 academic health science networks. We all have very different geographies and local population needs, but we're all brought together with a very common purpose about encouraging spread and adoption of innovation throughout. We do this really through creating the right conditions for change, and we do it through building networks, building collaborations, and really connecting partners across sectors. Now, we work on a number of different initiatives. What we're talking about today, as I've mentioned, is an initiative through the Accelerated Access Collaborative. And the AAC is an NHS England hosted initiative that basically brings together life science sector organisations to really support the NHS to adopt clinically and cost-effective new innovations at pace. And this is always linked to NHS priorities, and what we're talking about today is really linked to the NHS Long Term Plan ambition to improve respiratory outcomes. So focusing in on asthma. So asthma affects over 5 million people across the UK, and the NHS itself spends £1.1 billion on that, on asthma, about 90% of that being on medicines. We also know that diagnosis is a real challenge. We also know that adherence to medicines is really, really variable. So in April 2021, the AHSN Network and the Accelerated Access Collaborative brought to life two really exciting programs of work around transforming asthma care, both of which were focused around innovations that have been proven to be effective and had nice approval, but had lower than expected uptake. And these have both really had common aims around improving patient care and outcomes for asthma. So the first of these was biologics for severe asthma. And for those that don't know, severe asthma is a type of asthma that does not respond to regular treatment. It's quite distinct from difficult asthma, and it's estimated that there's about 200,000 people in the UK that have severe asthma, or about 4% of the asthmatic population. So whilst these numbers obviously seem important, I think it's really important to understand the suffering that kind of represents, and these patients are very, very unwell. Typically, they have multiple hospitalizations, and they live in fear of life-threatening asthma attacks. And often they become reliant on oral steroids, which we know have really, really quite harmful long-term side effects. So biologics are treatments that can be life-changing for these patients, and there are currently 5 NICE approved biologic medicines. Of which I think about, from the 200,000, there's about 60,000 people who we think would be eligible for these drugs, but currently only 20% are actually getting them. So a huge opportunity there to really improve access. I'm going to pass over to Joe to talk about FeNO.
Thank you, James. And so the second of our 2 national asthma programs is supporting FeNO testing. So for those of you who have not come across FeNO, fractional exhaled nitric oxide. It is essentially a gas analyzer looking at nitric oxide within your exhaled breath. And nitric oxide is a proxy for inflammation within the lungs. It's not the be-all and end-all of asthma diagnosis. It's one piece in a wider jigsaw. So it's a complementary test to many other tests. Spirometry is often the most commonly cited and known test. And ultimately, it's trying to add another piece of diagnostic knowledge in that diagnostic jigsaw. I'm going to start talking about how we've gone about some of our programs and how we've gone about some of the delivery. So collaboration has been fundamental to this program from the outset and at every level of our delivery. You can see our 4 fabulous clinical leads on the left-hand side, Natasha, Grenier, Tom and Andy, although Grenier stepped away from the program recently and we've got a new clinical lead, Bed Bostock, who's coming to become involved. And on the top right, you can see all of the many different partners who are part of this work, all coming together. The collaboration takes place at probably 3 core levels. We've got our national level, our national working groups. We've got all the AHSNs coming together in a collaborative way to support the delivery of this work. And also we've then got the local delivery and local collaboration, which is between AHSNs and their local system and local system partners. Talking through a few things around some of the critical success factors we've come across, and I'm going to go through these relatively quickly. We've had really clear and complementary aims, and people have really been able to understand what they mean and mean to them. We've also had a huge level of interest from bottom up to and top down, so we've had individual GPs or individual PCNs really, really keen, all the way through to systems, whole systems looking at all of this work in a collaborative way. We've got some detailed resources, and James and I are going to speak about them in a little more detail on the coming slides. And the AHSNs have really applied their knowledge of spread and adoption and how technologies get implemented to make this happen. We've got patient partners on both programs, and they've been fantastic, and we're going to hear from Emma, one of the Fino patient partners, in a minute. We've got a pre-recording of her. And then a couple of points together. The local knowledge that the AHSNs bring and the hard work of the teams has really helped drive this forward. There's been some fantastic engagement from all the AHSNs, and they've really, really pushed this work fast. You could say that this program is focused on products, but actually we've approached it from solely focusing on the pathways that they sit within. Ultimately, unless the pathways are right, these technologies, whether it's FeNO or the drugs, they're not going to have the impact that is required. So we've got a huge focus on the pathways. Just coming back to the top right point around spread and adoption, there's lots of work out there around implementation science, and often you could criticize implementation for focusing on technologies too much. We've taken an approach across both programs to really focus on the adopters, the people who are going to use these, and that's where most of our work and most of our time's gone. And I think that is probably, for me, one of the biggest critical success factors we've got going. So just to talk about the Phenotool Kit, this is on the Wessex AHSN website. You can access it with the QR link or the web address at the bottom. Fundamentally, it's a one-stop shop to help implementation of FeNO, and the resources on there are really extensive. And they fall into 3 broad groups. There's some stuff about FeNO devices, and that's a small area. There's a load of information on care pathway, including 2 HEE-developed training modules, which are really getting a large level of uptake. And there's wider change management information on there, so action learning sets, project plans, business cases, so on and so forth. We also run a national learning collaborative to try and bring all people who are using FeNO together, whether they're new to it or old to it. We're trying to bring everybody together. So this is really wide, free to access, anyone can use it, toolkit. So please use it if you're interested. James.
Thanks, Joe. In a quite analogous way, we've also developed an Asthma Biologics toolkit to really help clinicians and commissioners and our AHSN colleagues really be able to improve pathways of care for severe asthma patients, and ideally help them be able to access asthma biologics at the end of that long pathway. We've developed, say, a number of things that can probably be divided into 2 categories. The first are around pathway improvement resources. We've developed with AstraZeneca's partnership a clinical audit tool called Spectra, which can help identify at-risk patients. We've developed a prednisolone dashboard with the NHS BSA that can really kind of show us where high prescribing of oral steroids for respiratory conditions actually is in the country. We've developed a number of case studies. We've developed a home care dashboard that helps our secondary and tertiary care specialists really understand how they can maximise resource for the use of home care. And then we've also developed a number of clinical education resources, so e-learning modules, as Joe's mentioned, resources and podcasts, and also even patient resources. And one thing we're really proud about is actually looking at also at the enhanced role of pharmacists in asthma care. We think there's a really big opportunity there to get them more involved. And like with Joe, our toolkit sits on the Oxford AHSN website and can be seen at the link below. Today, I've mentioned the Consensus Pathway, and that really brings everything together. So all of these wonderful resources are actually brought together into a single pathway that also includes some kind of recommendations around kind of best practice in the care for severe asthma patients.
I'm also going to release a new resource that we've built for that supports both programs. What we've done is recently translated our key patient leaflets into 7 languages and corresponding audio versions, which you can see on the left. To support this, we've just done some work to map where those languages are spoken. Now, clinicians probably have a pretty good understanding if there's a large population locally who speak a non-English based language. But actually, there might be others who speak and are a smaller population. So we've created some interactive mapping, which is going to be released today on our website, which allows you to dig through and understand where are the people speaking these languages living, and how can we help get them the right care through asthma provision. And you can see just 2 screenshots there of Arabic and Polish speaking across the country. We've now got a short video from Emma, one of our patient reps, talking about the impact of
My name's
FeNO.
Emma. I am 44 years old and I live in Aldershot in North Hampshire. I'm married to a Grenadier Guard and we have 2 children who are 18 and 14. And when I talk about myself as having asthma, they are also part of the asthma. And although they don't have it, they are affected by it on a daily basis. I was introduced to FeNO sort of part way through my asthma journey, and for me it revolutionised my care. I think what it did was it showed clinicians that I did have this inflammation in my airways. So although I was on steroids and prednisolone, my inflammation level was still really high. So it was decided that I would actually be suitable for biologic therapy, and was as such referred to Southampton Hospital, where I since began my therapy. Unfortunately, the first one that we tried hasn't worked on me, so I'm waiting to start a different one. But the care that I now have is focused around this inflammation, and it's able to tell the clinicians how I'm feeling and get me on that correct medical pathway instead of just pumping me full of steroids, which were having no effect.
It's really nice to hear from Emma to sort of understand what the work we're doing is having in terms of an impact on her life. Talking about our wider impact, it goes beyond just supporting the use of these devices. I'm not going to go through all the stats on the screen now. The one I am going to mention is top left. We've estimated we've helped impact over 100,000 patients, and you can see just numbers are growing, and there's a great critical mass behind some of the work we're doing now. And our work goes beyond just uses of device. We're getting into workforce development, and hundreds and thousands of hours of training have now been delivered, and we've got a huge level of access to the resources that we've produced.
In terms of the asthma biologic impacts, I've just brought this slide together based on the metrics that we're tracking over the course of the programme. And this really just shows the difference of where we've started at the start of the programme to where we are now. I think it's important, obviously, to caveat that there are other kind of contributing factors to this, but we're really, really pleased to be able to see things moving in the right direction around home care prescribing, also around oral steroid prescribing. We can also see that in terms of primary care improvement work and early identification of potentially severe asthma patients, there's been at least nearly 300 practices that are using our Spectra clinical audit tools, with many more using other kind of bespoke searches. In terms of our engagement in our events, we've had over 1,000 HCPs attending our live events, with many more accessing online. And there's been nearly 9,000 Toolkit users now, which is really, really exciting for us and gives us a really good kind of level of confidence that what we're producing is useful and valuable to our clinical and commissioning stakeholders. In terms of biologic access, we've also seen in the last year over 2,000 additional new patients accessing asthma biologics, which is huge. And as I mentioned about these therapies really are life-changing for patients. I think that represents a really good improvement. in asthma care. I think it's now with great pleasure that I can I can announce the launch of our AAC Consensus Pathway. As I mentioned at the start, this has been the culmination of a huge amount of work from a huge number of people. The charge has really been led by Dr. Natasha Rupani, who's been our clinical champion and been really passionately driving this forward. And we've got a short video message from her now to introduce it.
Hi, my name is Natasha Rupani and I'm an asthma doctor. I work in Southampton. Thank you for inviting me to speak, and I'm so sorry that I couldn't join this fantastic meeting in person. So I've been working with the Accelerated Access Collaborative Asthma Biologics team, and over the last 12 months, we've worked with relevant stakeholders, clinicians and patients, and I'm delighted now that we are launching this consensus pathway for the management of uncontrolled asthma in adults. So why do we need why have we done this pathway? Well, we know that there are patients with uncontrolled asthma, and these patients have frequent exacerbations, sometimes sort of 2, 3, 4, 5 times a year that they require corticosteroids, and these have huge impacts on their lives. We now have treatments that can prevent these exacerbations, but nationally we know that it can take years for patients to be recognized and for them to then finally receive specialist input, and there are many reasons for this. But to try and improve outcomes for patients with uncontrolled and potentially severe asthma, there's two main themes. And sort of one is the earlier identification of patients, and once they're identified, reviewing them, optimizing them as much as is possible. And this could be things such as inhaler technique, improving adherence, smoking cessation, lifestyle advice, and then referring them when required. While for others, it's sort of streamlining the initiation of biologics and other treatments. This happens in severe asthma centers. So really, this pathway, as you can see, is bringing together all of those elements, so that primary care, secondary care, and severe asthma centers, and providing an integrated framework, which ultimately we hope will improve patient care and lead to fewer exacerbations and improved quality of life. So I will just go through a few screenshots with you, and these really don't do any justice to the whole pathway because they are really just screenshots, but I do want to share them with you. So in terms of the primary care section, we've got some information on identifying uncontrolled asthma, key elements on what to consider when optimizing patients in primary care, and then when to refer, with sort of support on referral templates and at sort of what point should that referral be made. In secondary care, we have some descriptions of what the key roles and responsibilities are, and also sort of guidance on structuring services. And here again, the focus is on delivery of asthma biologics, because we recognize as more patients are identified and referred to asthma centers, there needs to be places closer home where they can receive this treatment. And so we've introduced a concept of tiers to allow expansion of care, but still ensuring the robustness of an asthma multidisciplinary team. And then in severe asthma centers, there's again a focus on delivery of biologics, with an emphasis that once a biologic is approved, that it's initiated in a timely manner, and then monitoring and follow-up of these patients, linking back in again into secondary care and primary care. And then finally, there are tools to support our patients, to empower them to better understand and manage their asthma, and then support shared decision-making. So I think in summary, this consensus pathway is here as a pragmatic guide. I'm hoping it raises awareness and of the consensus best practices. We've tried to provide some frameworks, to provide some timeframes to help guide best practice and reduce variations in care. And again, like I said before, for some patients, this involves early identification of potentially severe asthma, while for others, it's more streamlined treatment delivery, and that'll have the most impact on their asthma and their exacerbations. And as we're now moving towards ICSs and sort of having local discussions, and I'm hoping that this pathway is there to shape those local discussions and to guide the development of asthma pathways, or the redesign of pathways at the local and the regional level. Thank you for listening.
So yes, as Natasha said, this is a really, really important piece of work, and it's really the first of its kind of pathway, really, for clinicians and commissioners and everyone involved really in asthma care to really use to try and improve now care for severe asthma patients. There's obviously a big piece of work ahead, and the AHSN Network are going to be trying to get behind this consensus pathway and doing its very best to try and help implement this. And it's been really developed through a number of different partnerships. So it's available today in PDF form from our Asthma Biologics Toolkit, and you can see again the link there.
So how do you get involved in this work? That's what some of you might be asking. So James and I, our emails are there. Please get in touch if you're interested. In terms of where we're going with this work, we've got about another 10 months of the national programme. Our ambition is to grow it even more and expand it even more and have even greater patient impact. So please get involved if you're interested and get in touch. Thank you. We've now got a little bit of time, 8 or so minutes for questions, and there is a roaming mic somewhere at the back. Anyone got anything they would like to ask?
My colleagues just kind of said that actually we can share the slides. I can see actually a lot of you are very interested in all the details, so we'd be happy to share these slides with you. I don't know if you can speak to Martin at the back if interested, then we can make sure you can get access to them.
I think, James, we'll also put them on our toolkit as, won't we, for people who can access them through that route as well, so we can do that.
Hi, it's just a comment rather than a question. So, as you know, I'm Natalie from the AAC, and I worked closely on the patient involvement. And I know not all of our patient partners were on the video, but I speak to them a lot in terms of our patients on FeNO and Asthma Biologics. And they give regular feedback on how much the programs have made a huge impact on their lives. And I know Emma touched on it a little bit today. But I know they regularly feedback. It's not just about the treatments and the diagnostics themselves, but it's the wider impacts on their family and how that impacts on the reduction in their hospital stays, the reduction in the number of hospital stays, which of course has a massive impact on their children, but also just feeling that their voice is now heard, that they're much more part of the system. So yeah, I just wanted to give a plug for, anyone working in healthcare, just make sure you involve patients from the early stage. And well done for doing so.
Absolutely, Natalie, and yeah, certainly we've had 2 excellent patient representatives on our programme, and they've really helped shape not only the kind of wider programme and what we've been really focusing on, but certainly the consensus pathway have been absolutely pivotal in there, and we've actually included one of our patients' stories, which is quite moving actually, so definitely recommend you have a look.
It was a great presentation, thank you very much. I guess the key focus is using FeNO as a screening to identify patients with uncontrolled asthma, to put them into biologics. What about patients with controlled asthma? Have you got any intentions to do further studies or further work that would help maybe patients who could potentially use personal admin tools to monitor peak flows, etc., to do something similar to support the wide population who have controlled asthma?
Yeah, I think it's a good question. I think there's quite an exciting future for FeNO coming, really. We're expecting about this time next year, NICE to release a new guideline, and we're expecting the management of asthma to be included in there formally, because it's not currently, so we're hoping that we see FeNO as a recommendation for the management. And then you can start using people in the way you say, bring people in as part of annual asthma reviews, and how can you say, are you on the right dose of medication? Can we pull people down in terms of the level of prescription and use less medication? Can we use FeNO to help change people's medication and get more environmentally sustainable inhalers, taking into account the fact that the NHS carbon footprint has got about 5% attributed to inhaler emissions. And I think there is a couple of suppliers that are coming to market with personal level FeNO devices. At the moment, they're all kind of professional, commercial grade things that are in hospitals and in primary care. But I'm aware of one that's developing something that's about the size of one of these microphones that they can use in their own setting in their own home. And that might allow them to monitor FeNO on a more frequent basis and start to capture when their inflammation is going up or going down, and actually adjust medication accordingly. So I think FeNO's got quite a bright future in primary care. And we're also exploring a few ideas around community pharmacy as well. We've actually got a conversation about that tomorrow.
Do you see a relationship between FeNO and peak flow meters? I know it's an old-fashioned technology, but it's very easy to implement. It's low cost. Is the focus with FeNO because you're getting more impactful results, or because controlled asthma is very much it's very much open feedback? You know, you take your drugs, you don't really know how you're doing. You go in once a year, and truthfully, the nurse doesn't really know how you're doing because there's no measurement. Yeah. So using maybe like personal apps to measure peak flow along with FeNO might be a more powerful combination for the future.
Yeah. Channeling Andy, one of our clinical leads, a phrase that he's been using a lot recently is taking guesswork out of asthma care. And he keeps banging that drum, and he's absolutely right, because if you can use FeNO to help take that guesswork out, you've got a better ability to control it. And we're not trying to pretend that FeNO is the only diagnostic measure for asthma. It's one small component of a much bigger pathway, and I think that's why our national program is focusing on the pathways, about how it's used, because the technology in itself is incredibly simplistic. You just breathe in it. The analogy I often give people when we're introducing it is it's simply like a police alcohol breathalyzer. If you're ever pulled over by the police, you breathe in it and it gives you a number. It's what you then do with that number, which is where the value comes in.
Any further questions? If not, I think we'll close there. I think I'd like to thank obviously everyone for listening. I'd also like to say a big thank you to everyone that's been involved in both programs. So all of our AHSN Network colleagues who've been working so hard, I think, over the last year to obviously make this a success, but also all the other partners which we have worked with, because it's been a really quite truly collaborative effort on all of this. So yeah, I just want to say a huge thank you before I close.
Thank you all.